Welcome back to Cardio-ECHO Tackling Type 2 Diabetes series. I'm Jessie Lewis, the clinic coordinator. We'll go through some of the usual reminders. Please be sure that you're chatting your name and your practice name into the chat feature so we can record attendance. We do have one slight change today. Dr. Duncan had a conflict, so Dr. Rao will go ahead and facilitate today's session. So without further ado, I'll turn it over to him and we can get started.
Sorry about that. I didn't realize I was muted. Thank you, Jessie, and thanks to everyone for joining us this morning. We have a great session planned with someone with a lot of expertise in diabetes in rural areas of our state, and that's Dr. Beverly, and I'll allow her to introduce herself very briefly. As well, we have other members of our team who would likely contribute to the discussion today. We've got Chris Taylor, who has a considerable nutrition expertise, and I see Jim Werner there, who has behavioral health expertise as well so far. So without any further delay, you want to get started?
Good morning, everyone. I'm Liz Beverly. I'm at Ohio University with the medical school. Should I just go straight into it?
Sure.
Okay, great. So these are the disclosure statements that have been sent to you ahead of time. And I am an associate professor in the Department of Primary Care, but I'm a behavioral researcher. So we're going to talk about type 2 diabetes in a rural context today. And so our objectives are, I'm going to describe some of the epidemiology research in type 2 diabetes in rural America. And then I'm going to have you, by the end of this, you can be able to list and describe at least 3 challenges or barriers faced by rural residents in accessing care, as well as helping them to manage type 2 diabetes. And then lastly, again, after watching this, you'll be able to list and describe at least 3 strategies to engage rural residents in helping to make self-care changes while taking into account their environmental context. Next slide, please.
Liz, didn't you want to do the poll right now?
Yeah, I do want to do the poll. So do I just go into, okay, so one of the things that I wanted to do is I wanted to try doing a poll this time. So we'll see how it goes. I have the first question here is for everyone on this. I wanted to ask the question of how many of you guys lived in a rural area? And the definition of a rural area is lived in a place that has less than 2,500 people. So there should be a poll popping up, and then I just want you guys to indicate yes or no. And then the second question is, have you ever lived in a major metropolitan area, which has over 1 million people?
I lived in a rural area. I didn't last very long.
And that's exactly why we're talking about it.
Okay, 82% have voted. I'm going to end it now.
Okay. This is quite interesting to see that, 58% have lived in a rural area. We have 42% who have not. And then looking at the major metropolitan area, which is over 1 million people, you see slightly over half, 63% have lived in a major metropolitan area, 37% have not. And I should have actually asked another question. Have you always lived in Ohio? Because I think that would also be quite interesting. So it's really important here that we have quite the mix of individuals here having lived in rural areas as well as major metropolitan areas. And I think it's quite relevant because Ohio has a lot of all of it. So next slide. So I personally have lived in both places. I was born in a rural town in Iowa that had less than 500 people. So no one has ever heard of the town. I've never met anyone who's ever heard of Sebula, Iowa, but that's where I was born. But I've also had the opportunity to live in Boston, as well as Rochester, Minnesota. So I've had the opportunity to experience a variety of places. And now I live here in Athens, Ohio, which doesn't technically fall under the less than 2,500 people. And that's thanks to the college students here in Athens, but it's considered a rural area. So you can see here in rural America, it's about 60 million people. So 1 in 5 Americans here live in rural America. I think it's really easy for us to forget that because we tend to focus on the coasts. And that's where a lot of our news originates from. Rural Americans face numerous difficulties, and some of these difficulties really hinge on accessing healthcare. So because of this, it contributes to higher rates of disease as well as disability. So there's a lot of different studies out there in terms of prevalence when it comes to diabetes. So some of the estimates, they range from 8% to 17% higher prevalence of diabetes in rural communities versus urban communities. Next slide, please. So when you're looking at this, it's also important to look at the access of care that's provided. So while 20% of America's population live in rural areas, these areas only employ 20% of practicing physicians. Now, thank goodness that we have nurse practitioners and physician assistants who also reside in the rural areas so they can provide primary care. But these rural areas tend to have fewer specialists, fewer dentists, mental health professionals, and pharmacists who are also practicing in rural regions. And you can think about how having these, fewer practicing specialists as well as the other healthcare professionals, how that can have an impact on access issues to care. And then the next thing that I'm going to be talking about are all the barriers that people in rural areas face. So you can see down the line how it has a cyclical effect impacting the healthcare and the health of individuals in rural America. One of the other things is in rural areas, they happen to have less access, and it's timely access as well, to emergency medical services, hospitals, and clinic. And part of that reason is a lot of these rural areas don't have their own hospitals. So if there is an emergency, they often have to travel to different counties in order to get emergency care services. So you can see how it's lack of timely access. And if they have certain clinics, a lot of times people have to travel to different clinics. So for example, I am located in Athens, Ohio, which is where we have Ohio University. So we have a lot of clinics here, but you'll see that people from all across the counties that touch Athens travel from those different counties to Athens, Ohio, because we have the school and we have the medical school. So we have these clinics here. And we also have Ohio Health Oblenis Hospital, which is a very small hospital, but is one of the hospitals where a lot of people from the surrounding counties attend. Next slide, please. So what are some of the barriers? This is not an exhaustive list. It's a list of a lot of the common barriers. And if you're going through this list, these are not necessarily unique to rural America, but these are a lot of the barriers faced by rural Americans. So transportation is a significant one. And I can describe to you the transportation barriers having lived in rural regions. So for those of you who've lived in rural regions, you know this. For those who've only lived in cities as well as metropolitan areas, there's a lack of public transportation. And part of that has to do with the fact that rural areas are very spread out and the population is less dense. And part of that also has to do with a lot of the rural areas have unpaved roads. So anytime there's unpaved roads, anytime there's extreme weather, for example, where I am now, a lot of the roads are not paved. They're very narrow. So if it rains a lot, and it happens to be raining in Athens right now, if it were raining for 2-3 days, the roads would flood and a lot of the roads would be closed. And so then school gets closed. So it's something that I have not encountered since I was a child in Iowa, but it's something that happens quite frequently here. So we may only get an inch of snow, but then the school district will close because some of these roads are so treacherous that school buses cannot travel on them. So it's things that you don't necessarily think about, like how could 1 inch of snow or how could 2 days of rain impact a community? But individuals will not be able to leave their house to go to a doctor's appointment. Individuals can't go to a grocery store. It really does have a huge impact on the lives of rural Americans. In terms of the access to healthcare, we already discussed about how there are fewer practicing physicians in these regions. They might have fewer clinics, fewer hospitals, dentists, mental health care professionals, et cetera. In terms of quality of healthcare, there's excellent primary care in these regions. It's not the quality of care necessarily, it's that it impacts the quality of care because there's less access. In terms of, there are fewer diabetes specialists, since we're talking about diabetes, it's more difficult to have an endocrinologist or a diabetologist in these regions, and people will have to travel a distance, which makes it difficult if there are already transportation difficulties. As I've mentioned before, fewer hospitals, emergency departments, and clinics. Financial constraints affect people in rural America. And part of that is there's been a loss of jobs in rural regions. And the cost of living tends to be quite stable in rural America. But if you do not have the chances for employment, and you don't tend to make as much money, which is why when Dr. Rao said, oh, I was in rural America, but that didn't last long. That's because if there aren't opportunities, you will leave. And so what happens is a lot of individuals who grow up in rural America tend to leave rural America for better job opportunities. And so what happens is you don't have people coming back and staying, so you don't have the job growth. There's less comprehensive insurance coverage. So what does that mean? Well, we had the Affordable Care Act, so a lot of people got insurance coverage, but not everybody signed up. Okay, so people went through the cracks in rural America. But also, when you think about it, having lived in some very urban areas myself, when you have an urban area, it's quite easy for organizations to form networks. So if you are going to do referrals, that they can do networks and they can have the insurance make sure that they cover and do within network. When you're in a rural region, it's much harder for private clinics or smaller clinics to make sure that they're referring within network. And sometimes the individual, it's upon themselves to make those decisions as to where they're going to go. And that's a lot to ask for an individual to navigate their own healthcare system. So a lot of times you have this lack of comprehensive insurance coverage because people might be paying more money to go to certain physicians or for certain services that might be with outside of the network. Food insecurity, we've talked about it. Dr. Rao gave an excellent didactic last week talking about this. This is an issue in urban areas. This is an issue here in rural areas as well. There are a lot of housing issues in rural America, and it's often just not seen, right? It's kind of a hidden issue. Just as there are housing issues in urban America, there are housing issues in rural America, and a lot of that has to do with the lack of job growth, the lack of opportunities here, and the financial insecurity. And then a big thing to really think about, and something that really pertains to people with diabetes, is when we're thinking about health. Health is much more than physical well-being. It focuses on emotional well-being and social well-being. And people who live in rural America, and you can think about this right now during the pandemic, that social isolation is a huge issue. And if you've been reading lay articles in the press, one of the issues that people talk about is the social isolation of older adults. And social isolation is a big deal in rural America because people are so spread out. So if you're talking about people with type 2 diabetes who have had to quarantine and self-isolate during the pandemic, but they're living in a rural area, it is going to be even more difficult. So it's just so important to consider all of these different factors, the social determinants of health, but some of the social factors that we're talking about too. Next slide. So I thought it was important for us to even consider, what does the state of Ohio look like? So this was put together by the Office of Rural Health Policy, just to get a sense, okay? So find out what county you're in or what counties you've lived in. So the bluest counties are the rural counties. And if you look at this, now I'm not originally, obviously I told you I was born in Iowa. I'm not originally from Ohio. So this was fascinating to me. The majority of Ohio is rural or partially rural. You have the urban counties that really come around the major cities in Ohio. You have the Columbus, the Cincinnati, the Toledo, and the Cleveland regions. And anything that's outlined, that you see that outline that comes from kind of like the Northeast, the Southeast, and the South part, that's all Appalachia, which all pretty much follows under the rural counties. Now, try to remember where the dark blue, or it's not really dark blue, the more shaded blue and then the lighter blue are, because I'm going to have Rick advance the slide. So just try to remember where the blue was. Now, this is focusing on the poverty in the region. So then look at the green and the red and the orange. So the parts that are rural are the same parts that have the higher poverty. Okay, so you can see this issue now. That does not necessarily mean that poverty only occurs in rural regions, because you can see up in the Cleveland area, there's some of these same issues. So it happens in urban areas as well. But if you're looking at this, a lot of this is happening in rural America. And a lot of that, again, has to do with loss of employment. There aren't as many job opportunities. So for example, when you have somebody who's bringing, I remember, was it a year ago, 2 years ago, when they were looking for a new place to put Jeff Bezos's Amazon, and Columbus was in the running. It was Columbus, right? No one was saying, let's go to Meigs County, right? So it's very challenging for people to have job opportunities. And for example, in Southeastern Ohio, the biggest employer is Ohio University. Next slide. And so then thinking about that, there's a combination of factors that you can look at when you're talking about the number of people in the region, as well as certain measures of poverty. And you can see whether or not you're designated as economically distressed. Okay, and so here is this looking at which counties in Ohio are considered economically distressed or at risk. Okay, and so this factors in employment, right? And so you can see here, again, it's the same counties, but really in particular, it's the counties in Appalachia, right? And that is a third of the state of Ohio. Next slide. So I just wanted to put this up. This is something that I worked on at Ohio University in terms of looking at diabetes rates in the region. So you can see here, so the CDC does a lot of estimates in terms of by county as well as by state for looking at rates of diabetes. But when the BRFS is doing these estimates for the CDC on diabetes rates, they don't necessarily sample from every county. They're doing a lot of statistical modeling, and they'll sample from a handful of counties throughout the state. So what we did is we wanted to kind of check, you know, how much in line are the CDC estimates with us conducting our own telephone survey in the region. Now, of course, we use CD3 2013 rates, and ours were in 2016, but you can see there is quite the discrepancy. So when you're actually taking the information from the county, and what we found is looking at all these counties, and we also included Wood County, West Virginia, because so many people from Wood County, West Virginia do come to Athens for their diabetes care. But the average was 19.9%. So 1 in 5 people in Southeastern Ohio have diabetes. The vast majority is type 2. Next slide. So what can we do? Well, I think one thing that we've learned from this past year is that telehealth can work effectively. And there's been some research that shows that telehealth is a very promising model for delivering diabetes education, management, and support. And so there have been interventions that looked at telehealth, and it does show improvements in A1C values as opposed to usual care. And this is really important because it can reduce the barrier of transportation. Now, the other thing to consider is, does the individual have access to broadband internet? And also, is an individual comfortable doing telehealth? So those are some of the factors you have to consider doing this, and being aware of resources if there is a need to do transportation to coordinate things, if you have to travel to a clinic. But there is very promising data for telehealth, and it looks like, you know, in the future, we're going to have the continued coverage for telehealth. Next slide. And then other things that have shown promising effect in terms of doing diabetes self-management, education, and support is anything that incorporates social support. Social support is so important for people with diabetes, especially for type 2, but it's equally important for people with type 1. So offering group diabetes education, whether it's in-person support groups, which are challenging to do right now, recommending online peer support has been very effective. Encouraging people to get together, to reach out with friends. All of this, of course, is constrained by the pandemic right now. Encouraging people to join clubs, activities, religious and spiritual groups, volunteer organizations, because again, it fills in that need for the importance of social connection. And then there's been some research, while I don't have it listed here, that's showing the importance of community health workers and lay-led peer support for diabetes education. That's been very promising in helping people with type 2 diabetes. Next slide. Okay, so does anybody have any questions about any of this? And I know we have a couple of people here who practice in rural regions, so feel free to add some information.
Thank you, Liz. If I could start with a question, I'm sure you'll have some others as well. ECHO started actually to provide care to support for physicians working in rural areas in New Mexico, and has been, you know, the whole principle is moving knowledge. You know, given the pandemic, given the rise of telehealth over the last year or so, how do you see the role of telehealth care for patients in some of these areas? Are they able to participate? Do you think that certain services could be delivered?
So I'll answer that, and then I'm going to tag Dr. Osley, who happens to be a practicing physician here, and she'll be presenting the case. What I would say is, anecdotally, what I've heard from physicians here is that the telehealth has been received quite well. A lot of the people here prefer the audio, like the telephone calls, not necessarily the video calls. So that's something to consider. But I know that a lot of people are more likely to keep the appointment if you do an audio telehealth. We do have a lot of internet issues down here. I'm sure anyone who's on cardio knows that I have internet issues. So we do, I mean, it's hard to believe that there are some counties here that really struggle with internet this day and age, but we do. So I don't know if anyone wants to add to that.
Right, I would just say, I mean, I've done quite a bit of telehealth during the pandemic, and it is very true that many of our patients do not have access to any sort of broadband internet. So telehealth is mostly telephone encounters here. We do have some patients who are fortunate to live close to the university or have the benefit of the broadband internet, but for the most part, it's very limited. It's either satellite or dial-up. So it does make it more difficult to do, you know, some things via telehealth, and also part of the culture here, folks are just not as comfortable with video communication. And so they, you know, or sometimes they have embarrassment about where they're living and how they're living. And so it can be a barrier. I've had people call me from their cars. Sometimes they will have a cell phone and they will call me and conduct the video literally sitting in their car. And then, you know, just the many patients that I have from the rural areas, which if you get 10 minutes outside of Athens, it's extremely rural. Many of them do not have computers or access to any kind of tablet. They may have a phone, a smartphone. And then you throw in this element of a completely older generation that just does not, you know, function with our present multimedia lives. So that they're totally cut out of this. So telephone at least is one way to stay in touch with them, and it has worked pretty well. I mean, at least we can keep some communication with them going, assess them for needs as far as if they need, you know, support or Meals on Wheels or something. We have been able to keep in touch with our higher risk patients that way. So it's yeah, it's definitely a whole new wrinkle to medicine in a rural area.
Thank you, Laura. Does anyone else have any questions?
I had a
If
question.
not, I just wanted to, sorry, please, Melissa, go ahead.
Oh, no, thank you.
Go ahead.
I guess one of the fascinating aspects to me within, you know, our rural and Appalachia regions is the impact of culture on health in this area. And while we know there's a lot of maybe more anecdotal evidence surrounding that role that culture plays, I just wanted to know if maybe you can speak, Dr. Beverly, and even Dr. Osley, about just that impact. I think sometimes diabetes can be so pervasive within families, within communities, that not even knowing that there's an option of improvement or that there are ways to you know, to mitigate some of the risk factors. And I just didn't know if you had maybe a brief overview about how that role of culture plays within telehealth, within our interventions in these rural Appalachia regions.
Thanks, Dr. Thomas. You can call me Liz. So that's a perfect question. So while this is broadly looking at rural context, when you add in Appalachia on top of the rural context, and keep in mind, Appalachia spans across 13 states. It's like 205,000 square miles in the United States. And if you're not a part of it, it's kind of easy to not even realize how big and expansive it is in our country. But Appalachia has a very distinct culture. And then not only that, parts of Appalachia have differing types of culture based off of what part of Appalachia you're in. So the part that I would say is in Ohio, and Melissa knows a lot about this too. It's really important to add that layer in and understanding the culture, right? And part of that culture is there is diabetes fatalism, where what Melissa was referring to, that because there are such high rates of diabetes in this region, people expect to have diabetes, and they don't understand that diabetes is something that you can work hard to prevent or to delay the onset of. And people just say, well, you know, my grandparents had it, my parents have it, my uncle had it. This is something that I'm just going to get and I can't do anything about it. They see it as their destiny. And I've done some work on this topic. So the diabetes fatalism is something that's really hard to address. I'm curious, you know, if Dr. Olsey has, you know, I'm sure she's encountered this in her practice. The other thing is just really understanding the people in this region, the history of why people came to Appalachia, just understanding that, because it really defines the core values and the strengths of the individuals here. You know, they really focus on being independent and self-reliant, and understanding that is really critical. And they really focus on the values in terms of family and what, you know, what truly matters to them, and being loyal to each other and caregiving. So really understanding the core values of people in this region is very important. And one of the other things to consider, which is very challenging, and I'm not a clinician, but understanding that there is a lot of hesitancy and not necessarily a willingness to trust providers, because people in Appalachia have been taken advantage of. And so, Dr. Thomas, if you even want to talk about this, because you do a lot of work in the region with community-based participatory research, if you want to even say something about that. But there's a, you know, there's a lot of distrust of outsiders in this region because people have been taken advantage of. So it's just important to know the cultural context.
Thank you, Liz.
Did either of you want to say something?
Yeah, I was gonna actually just shift this back to Dr. Osley, just from a clinician perspective, and certainly can add to that if needed, but would love to hear her perspective on this issue too. Thanks.
Laura, you're
Sorry.
muted.
Yeah, sorry. It took me a second to figure out where to click because I have the big grid view on. So I am actually from Southern Ohio. I was born and raised here in a very rural area, grew up on a beef farm, about 110 acres. And my nearest neighbor was about 3 miles away. I had, so the town that was closest to me is about 700 people. That's the total population as 2019. It's an area of people who I think moved to this area there were coal mining, and most of the folks are from either like Germany or Irish and Native American here. So we have a mixture of those ethnicities. The culture is very much about family and being self-reliant. People do have gardens here where they grow their own food, and they have most of the food that's grown is corn and potatoes and starchy foods, as you can imagine, because those can be stretched and go a long way. But then red meat, beef is a big deal. So the people, if you can imagine, also, you know, just food is a big deal for the families as far as maintaining a security for them. And people, all of our events center around food. It seems like, which I guess is in a lot of cultures, but here also this area has been devastated by decades of economic suppression, and really was devastated by this pandemic of opioid addiction. So the structure of the culture, there's small areas where people are prospering because they have land and they have the ability to protect their own, but people are very close knit, like she's saying. They care about people. It's a Bible Belt area where people do have a lot of spirituality, but they also are just very much like, I'm going to take care of mine, you know. And then those who have shifted or have experienced decades and decades of poverty, of not being able to pull out of that cycle, they've spiraled into just a way of living that is very dysfunctional in a lot of ways. And, and people are dealing with addictions, which compounds all of that. And so it's a really tough area, but having grown up here and experienced many sides of that, it makes it a little bit easier to kind of manage or know what these people are dealing with. So definitely, yeah, this is a very interesting area to live in, and there's so many aspects of what makes a person well, and their, to focus on in their whole, health.
Thank you, Laura, for that perspective. It reminded me a little of an article in the New York Times many years ago about President Johnson's war on poverty in Appalachia. And the second sentence was poverty won, basically won the war. And there's a sad thing that I think Liz was hinting at, is that people with skills, with a higher level of education, tend to leave. So the people left behind, unfortunately, are those without skills, without jobs, who are more prone to diabetes and other illness. And it's an endless cycle. So I salute you for sticking with it and trying to help the communities that you live in. I think we've got to 8:33. I think, Laura, we can move on to the case study, which I found really quite interesting. Does anyone have any questions before we get to Laura's two main questions about this woman herself, and we turn it over to everyone? Laura, I just want to ask you, she mentioned that she was on Januvia DPP-4 inhibitor for many years, and apparently she's not taking it anymore. What happened there?
I think it was mainly just that she started having her decline, and we were not seeing enough improvement from the efforts that she was making. So I think that's the point where I switched her onto insulin. She is
okay, so it just wasn't effective.
Right, it was not really that effective for her. I may have, yeah, I'm not exactly sure, because we had an electronic medical record to change, so I don't have the exact timeline, but I think that's what it was, is we were just struggling with her control, and I was looking for something that was really going to help us get the additional drop in A1C that we wanted. She tolerated it well, so I might reconsider, adding something like that back in.
Sounds like an interesting idea. The other, maybe suggestion from my standpoint, and ask others to weigh in as well, is that if she's not able to tolerate a weekly GLP-1 agonist, and I don't know if you use Bydureon or Ozempic, whatever they are,
Yeah.
And we do this in our Fit or Me obesity program as well. So we start with a daily GLP-1 agonist, Victoza, at a very low dose for 0.6 milligrams per day, and keep it going at that. Actually, Sherry Bowman has the same question. Keep it going at that dosage for a whole week. So 0.6 for a whole week. She is going to experience a little bit of nausea, and then go up to 1.2. The maximum dose is 1.8. And that's a way of overcoming some of the intolerance that you're experiencing. My fear is with all that insulin, with short acting and long acting, she's just going to gain a lot of weight. And she is she has a high degree of obesity for age 70. And she's very sick. She's got non-proliferative retinopathy. She's got coronary artery disease. I'm presuming, I don't remember what her renal function is like. So this poor lady is really, really quite ill.
Still pretty good, but yeah. Yeah, I may. So we have the wrinkle of her insurance just changing over. So I have to explore, what is going to be on her formularies. I've struggled this week with the insulin, trying to get the mealtime insulin that the insurance will cover, but we were able to achieve that. So that's why she is able to have those. My hope is not to have her on such a complicated regimen for very long. I was trying to help her get back some control and get her out of such a high A1C range, and then continue to work on, actually simplifying and stepping back as she gets a handle more on her depression. And, and we can, like I said, we can re-explore adding in more, of the newer agents again, to see if we can get her, get her losing some weight. I have not tried Ozempic with her. Do people experience in your experience less of the nausea with Ozempic or one of the other brands versus the Bydureon or Ozempic?
Well, I think all GLP-1s slow gastric emptying that will all result in nausea and sometimes vomit, sometimes even diarrhea. So the key, I think, is to start at a low dose and not expect any improvement in control on those low doses, and then gradually go up. So whether it's Ozempic, whether it's by exenatide, or if it's liraglutide, whether it's long acting or short acting, doesn't really seem to make a lot of difference. Okay, thank you, Laura. I think we have a couple of major questions that Laura wanted to address. The one I'm not too clear about, the transition from her commercial insurance, which I assume is provided by Ohio University, to a Medicare plan, and leave that to others. But I wanted both Chris and Jim to talk about how to get this lady started with some lifestyle change. And to me, this is not a hopeless situation, but it seems like it's going to be very tough. First of all, for her to lose a significant amount of weight through exercise is going to be pretty unrealistic. And I would say, hey, to someone like this, you even think about bariatric surgery. But Chris, your thoughts on lifestyle to start with?
Yeah, and knowing all the other problems that she's got as far as the arthritis, weight bearing is probably not going to be an easy option for starting out, but the ability to do more resistance activities, even resistance bands, being able to sit and to be able to do some of these strengthen activities, building up some lean mass, which will help resting metabolic rate, getting the muscle contractions, which will help with diabetes. Those are going to be kind of simple strategies that she can do. It'll probably help with pain. It'll probably help with mobility, which then may start to make all of the other things not so bad. And if she can make some small progressions there, then it may pay bigger dividends on as she continues to progress. And I think with the dietary pieces, just the idea of going from, okay, we're going to eat this way, now jump to a vegetarian diet, look for smaller opportunities, look for places where we're looking at carbohydrates across the meal, and are we being more starchy, which has a tendency to be the case? Where can we cut back on those? As Dr. Harter was speaking, I actually show a picture of our family's potlucks at the holiday time in my community class and tell them to count the starches. So being able to look at what people are consuming and kind of find what some of those trigger points are and start to just scale back instead of trying to make drastic changes of how do we jump to a vegetarian diet. There's a reason why she didn't do it, so we can find out what were those major shortcomings, what does she struggle with, and then you can find small strategies to address those gaps of why she had those struggles the first time that she went through. And I'd be interested to hear Jim's comments as well.
Thank you, Chris. Those are excellent comments. I think the key is really incremental behavior change. There's a phenomenon in the obesity world called novelty seeking. And those are people who go from diet to diet, new exercise equipment, new class, etc. And they, of course, people spend $100 billion a year on new approaches and they never get anywhere. And hopefully she doesn't fall into that category. But Chris's suggestions are very prudent, I believe. Jim?
Yeah. I just want to, give the provider some credit here for all the work she's been doing with this patient, and not an easy patient to deal with. And this patient's gone through a lot of significant life changes with her retirement, her professional identity, no longer being what it was before, and perhaps retiring at a time when she didn't plan to retire. And I've seen this with a number of patients in our our clinics, excuse me, who have had forced retirements and the effect that it has on their self-esteem and dealing with depression in particular with this patient. So depression, of course, can greatly reduce the amount of motivation people have to make changes in their lifestyle. So I think you're really on track with get the patient either, if they can be on medication, if they're willing to do that, as well as counseling because of these significant lifestyle changes and losses that she's experienced, family members during COVID as well. So probably more than medication. In addition to that, she has a lot that she probably would like to work through and would benefit her significantly if she can talk with a counselor on a regular basis. Being an educated person, I'm hoping she would be open to doing that. Even in a rural community, sometimes there's more stigma.
Yeah, that's what I was going to say. In her culture, it's definitely a factor of as far as the overall the stigma of mental health.
Mm-hmm.
And so she's open to the idea of counseling. Again, just making that happen is going to be a little bit of a struggle. There's always a wait. I'm not sure that I can convince her to take a medication for her depression, which is significant and has been going on for several months. So,
okay.
Yeah.
Yeah, it does pose some challenges. And sometimes people are more open to going to a counselor at their church or someone who's not truly, has the title of counselor, but has some skills that can help them perhaps work through what they're doing, and just someone that they can talk to openly and confidentially and share, what their life experience has been the last year or so and the difficulties they've had. So that can be helpful. Also, I completely agree, with Chris and Gautam on their observations and suggestions about incremental small changes. So a person like this, trying to move her towards exercise is a significant step. And I just looked on YouTube a minute ago, and because I recommend this all the time, if she has an internet connection that is at all reasonably decent, there are more than 30 different videos that came up immediately for people with joint pain, limited mobility, and wanting to exercise. And some of them are specific for exercise for weight loss. So this is something she could do in her home with, they show a personal trainer on the screen who's doing chair exercises and walking people through things. So there's a lot of resources there. And it's great that she has equipment in her home as well. But it sounds like to date, the motivation has been the big challenge. And if you have access to community health workers in your community who can provide support, come by and see her, perhaps engage with her in doing some chair exercises, maybe using a video, or just help her get started with 5 minutes of exercise on any piece of equipment she has. We had a support group last night with a woman with similar BMI who saying that because we had recommended just starting with 5 minutes, and 5 minutes has been a challenge for her, but rather than saying 30 minutes is what we recommend, you need to do 30 minutes, would have been overwhelming for that patient and maybe overwhelming for this patient too. But just starting very small, get on the equipment and just reacquaint yourself with it on day one. Don't worry about the time. The next day, get on it and see what you can do for a few minutes. Work up to 5 minutes and just have the goal to make it a daily habit of just getting on that equipment, regardless of how much time you can spend, because this is going to help your mood. This is going to help with weight loss. It's going to help with diabetes control, et cetera. So it's a challenge because of depression as I see it. And in my mind, that would be a potential obstacle that needs to be dealt with.
It is.
If you can deal with that first, but you can work at them all simultaneously and see what the patient will respond to.
We do have, I mean, we are fortunate in Athens, and she's only about, like I said, 10 minutes away from there. She would have access to our community center here, which does offer things like classes on chair volleyball and chair exercise, as well as they have a nice walking track. It's indoors. We're also fortunate to have a beautiful bike path that goes around our community for many miles. But I think I think the thing is motivating getting her to come to the community center and utilize that, as well as, I'm not sure that she would feel confident walking on the bike path where so many other people are walking. And also, the consideration of the pandemic, still, we have a lot of really young college students who are in our community at all times. And so there's lots of advanced people who are biking and jogging, running things on that trail that might intimidate her. So that's been part of the struggle too, and getting her to utilize some of those things.
Mm-hmm. Yeah, it's great. It's a great resource that you have if you can persuade her to go there, perhaps with someone else, a friend, family member, that might make it easier for her the first few times, and get acquainted with that. And socially, it could be really helpful on having a social interaction. It sounds like in the situation that she's in right now. So
Laura, on Jim's point, I just had a question. What is her husband like? What's his health like? And is he supportive?
Actually, I've never met him. I don't know. And she doesn't really share much about her situation. So that's why I'm hoping to kind of really investigate everything that's going on. I don't know, his health, I imagine, is not really that great either. I think, there's more to the story that I don't know.
Mm-hmm. Okay, thank you. So I just want to kind of summarize. Liz has made some excellent suggestions here on the chat about cognitive behavioral therapy and exercise, as well as some recommendations for community health workers. So community health workers are instrumental through their contacts in improving diabetes control, and there are apparently community health workers available in the Athens area that you could take advantage of. So terrific case. Thank you so much for sharing her story with us. I'm going to turn things back to Jessie for a moment.
Great, thanks everyone. Just a reminder, we have the recordings of these sessions on our website, cardio.org. For this current series, you will need an account, which I know we've said before. Please feel free to reach out if you need help activating the account or accessing any of the recordings. We're happy to troubleshoot. You should have the post-clinic survey for today's session in your inbox already. A reminder that those do close tomorrow at 5. And then we only have 2 weeks left. So just a heads up that next week I'll be providing some more detail about how to claim CME credits and some of the wrap-up surveys that we will be sending out as well. So with that, I'll go ahead and end. I know it's 9 o'clock. Thanks for joining, and we'll see you next week.
Thanks, everyone. See you next week.
Everybody.